you would just introduce yourself and we'll get started with your presentation.
Sure. Well, Steve, thank you so much for having me. It's really an honor to be giving this presentation to the members of the ICOS. Say that about 15 years ago when I was a fellow, I remember being asked to give a lecture on atrial fibrillation, and as I was preparing for it, I actually went into atrial flutter myself. So I'm always about giving presentations on topics that scare me a little bit. So hopefully I don't come down with any sort of myocarditis after this presentation. So the talk today is checkpoint inhibitor myocarditis. It's an interesting case that I'm actually managing right now. I wanted to share it with the group, possibly get some thoughts from the group, from people who may have some experience with this, and go over a little bit of the diagnostic and therapeutic strategies. So to give you a little bit of background of where I am, because I know there's people from all over the world here, I'm from the Chicagoland area, and my hospital system is in the North Shore of Chicago. So here's Chicago right here. Here are the northern suburbs of Chicago, also called the North Shore. And for people not familiar with the North Shore, a lot of movies have been made here over the last 3 decades or so. So Risky Business, Breakfast Club, Home Alone, 16 Candles, and of course Ferris Bueller's Day Off. So all these took place here in the North Shore of Chicago. That's what we're known for, amongst other things. So here's the case, and again, I apologize. There's a little, there's an area on my screen where I don't see the top right 15 or 20% of the screen. So if I don't see a couple of things, I apologize in the presentation. I'll do the best I can. So this was a man who's been my patient for the last decade, who in January of 2019 started his new medical journey. He, in January of 2019, 77 years old, past medical history of coronary artery disease and AFib. He had bypass surgery in December of 2010. He had both bypass and maze at that time. Unfortunately, the maze did not work, and he has had persistent atrial fibrillation since then. He also has high blood pressure, diabetes with pretty significant diabetic retinopathy. He's blind in his left eye. He's done reasonably well, though, for the past 10 years, despite his blindness. And in January of 2019, he presented with cough and shortness of breath. So just to give a little bit of a background here, with respect to his cardiac history, here's a nuclear stress test that I had done a couple years earlier in November of 2017. And it was a pretty good looking stress test, maybe a little bit of lateral ischemia. You can see some reversibility here, but no symptoms of angina at all. Really rock steady cardiac status, normal ejection fraction. He did have some symptoms that were somewhat concerning for angina in April of 2018. His angiogram, though, was for the most part fairly benign, with a mammary artery to his LAD that was widely patent. His vein grafts to his right coronary artery were fine. He did have a vein graft ×2 that were occluded to his obtuse marginals, which probably explains the ischemia that we were seeing a year earlier. But the decision was just medical management, and he had done very well with medical management. In March of 2018, again, about 10 months before his presentation of January of 2019, he had an echocardiogram that showed, again, preserved ejection fraction of 53%, some moderate left ventricular hypertrophy, moderate TR, and then evidence of an old infarct in the basal inferior infrareceptoral walls. His medications at this time in January of 2019 included insulin, rosuvastatin, aspirin, Coumadin for his AFib, losartan, amlodipine, furosemide, chlorthalidone, and Imdur. And with that cocktail of medications, having really no angina at all, no heart failure symptoms, doing very well. And now new diagnosis of cough and dyspnea. So this was presented to his primary care doctor. His primary care doctor did do a CAT scan on January 15th of 2019. And you can see on this CAT scan here, on the left, he has this pleural base mass, and on the right, he has this 3 centimeter mass in the left upper lobe. So it was read as multiple left pleural nodules and masses, 3 centimeter left upper lobe mass, thought to be bronchogenic carcinoma, very mild left hilar and mediastinal adenopathy, and then 3 subtle hypodense lesions were noted in the liver. So 6 days later, he got a PET scan, and here's his PET scan from January 21st, 2015. I'm sorry, this should actually be 2019. I apologize for that. And there was a hypermetabolic left pulmonary mass, and you can see the mass as well as the pleural-based nodules that we were seeing on the CAT scan. So on January 24th of 2019, he had an ultrasound-guided FNA and core biopsy of the mass in the left lateral thoracic wall, and it came out to be metastatic melanoma that was BRAF negative, the wild type. So it was decided to have him see an oncologist, and he saw an oncologist in January of 2019 after the diagnosis, and he was started on our PD-1 Evo or Opdivo, and he had treatments on February 7th, March 7th, and April 4th, so 3 cycles. And you can see he has a beautiful response here where there's a significant decrease in the size of this left upper lobe nodule, and most of these pleural-based nodules had essentially resolved. There was also regression of the left hilar adenopathy, and the node that he had at the left costophrenic angle had completely resolved. So a really nice response after 3 months of immunotherapy. So it was decided to continue the immunotherapy for another 3 months or so. And here's more Opdivo, May 2nd, May 30th, and June 27th. And again, here's his initial PET scan here. Here's the subsequent PET scan number 2 in April, and now here's his PET scan in July of 2019, and just fantastic, a complete remission of this stage 4 melanoma. So it was decided to continue with treatment throughout the summer of 2019. So he had 3 more treatments, July 26th, August 22nd, and September 19th. And what was noticed on the subsequent PET scan in October of 2019 is that there was some hypermetabolic activity noted in the sigmoid colon, undetermined if this was related to effects from the immunotherapy or it could be from current disease. And then one thing we're also noticing here is a new hot lymph node in the left external iliac chain. Again, uncertain at this time if this was recurrence of disease or if this is just related to maybe some colitis from the immunotherapy. But he was given reassurance and again, still satisfied that the disease in his chest had completely resolved at this point. So from October of 2019 till December of 2019, he had 2 more treatments with the Opdivo. And again, what we're seeing here is this hot lymph node in the left external iliac chain, and perhaps some mesenteric lymphadenopathy as well as a new lymph node that was adjacent to the spleen. It was still unclear at this time if this was truly recurrent metastatic disease or potentially related to the immunotherapy. After discussion with his oncologist, thought was melanoma versus inflammatory node versus immunotherapy versus infectious. So during this time, December of 2019, now almost 1 full year after his diagnosis of metastatic melanoma, one of the side effects that he was having from the Opdivo was persistent thrombocytopenia. Here we are in January of 2019. And here's our platelet count, which was normal. And as you can see, it dropped in the summer of 2019 and was persistently down somewhere between 100,000. And then in the fall of 2019, his platelet count dropped to less than 100,000, which was thought to be related to probably an ITP related to the immunotherapy. Keep in mind, he is on Coumadin and aspirin at this time for his AFib and his coronary artery disease, having no bleeding issues, but the thought was that he was having fairly stable disease this time with respect to his melanoma, and it was decided to hold immunotherapy at this time in December of 2019. So from December of 2019 until March of 2020, this takes us up to just a couple of months ago. The Opdivo was held mostly for the thrombocytopenia. He also did have a little bit of a rash, but that by itself would not have warranted holding therapy. And what you can see is now he has multiple new lesions on his PET scan from March of 2020. First, this lesion in the left external iliac region has definitely become larger and more intense. There are 2 new hypermetabolic mesenteric lymph nodes in this area here. Again, this lymph node adjacent to the spleen, and now we're also seeing a hot spot here in the right lobe of the liver. So fairly convincing evidence that he does have recurrent disease at this time. And so management was to restart him on therapy. And it was decided at this point that on April 7th of 2020, so about 6 weeks ago, we would start him on Yervoy, or I should say the oncologist decided to start him on Yervoy.
Hey, Jason.
The response that he had to the PD-1 Opdivo.
Hey, Jason.
Yeah.
Yeah, this is Dan Lenahan. Thanks for doing this presentation. It's really amazing, but it does bring up a lot of interesting points, or I'd at least like to hear what you think about it. If you could go back 1 or 2 slides, yeah, that one right there, perfect. And then in a minute go forward 1. But if you just look at this slide, and you of course were talking about the hypermetabolic lesions that they were focused on, but if you look at the cardiac uptake in July of 2019 and then in December, you think that maybe there's something different. And if you go forward 1 more slide, that one. And in March of 2020, look at the uptake of his heart. And I would be curious, was that commented on, or is that anything involved in the decision making as to why there was such a difference in cardiac PET uptake from a year and a half ago to now?
That's a great point, Dan. And no, this was not commented on by the radiologist. And at this point in March of 2020, because he had been doing very well from a cardiac perspective, I was not involved in the case. So I had not seen him for probably about 6 months at this point. The last time I had seen him was in the fall of 2019, when he was doing very well with respect to the melanoma treatment. So at this point in March of 2020, I was not involved as the cardio-oncologist. But I think that's a great point, and it's clear as day that there certainly is significant uptake there that's seen in the myocardium.
Yeah, so I have struggled with what this means in various PET scans that have been obtained in the past. In this guy, you know, I would probably come to 2 conclusions, and I don't know if either one of them is correct, but one is, you know, and I guess 3. There are 3 possibilities. So one is that he has now become ischemic, where he wasn't ischemic before. Number 2 would be that he had, you know, focal involvement of his melanoma, but, you know, that looks more like global uptake as opposed to focal. And then the third would be, if somebody was developing myocarditis, could you detect it by a PET scan?
I will say that here in March of 20, at this point, when they did decide to restart therapy for progressive disease, he was not having any symptoms at that time that would suggest myocarditis.
Yeah, but it's a tricky diagnosis.
Obviously. Yeah, very tricky, very tricky.
So didn't mean to interrupt your.
No, it's a great point, and I thank you for bringing that up. Thank you for bringing that up. So, so again, April 7th was the day that Yervoy was initiated, and on April 8th, one day after his Yervoy, is when I got a call in my office. Again, I hadn't seen him in about 6 months, and he tells the nurse that he can't get a deep breath. He's had no cough or fever at that point. Again, my concern was, because this was within 24 hours of his first dose of his second immunotherapy, that maybe this could be a myocarditis. Also on differential would be ischemia, and less likely COVID, although possible, since we're living in a different time right now. And I think COVID is always on the differential, especially in a man in his late 70s with diabetes and coronary disease. I talked to the patient on April 8th, and I instructed him to go to the emergency room for an EKG, troponin, pro-BNP, and a chest x-ray. And throughout the day on April 8th, I'm waiting for a call from the emergency room telling me how he's doing, results of his tests, and I never got a call. And I realized the next day I never got a call, and I called him, and he told me that his primary care physician told him to not go to the emergency room due to concern of COVID. So here on April 8th, these are the cases of COVID in Illinois, starting back here on March 10th of 2020. And as you can see, the cases were growing exponentially at this time. So I could understand his primary care doctor's opinion that going to an emergency room where there were going to be certainly cases of COVID. And again, so far in our institution, we've had several hundred patients who've been hospitalized for COVID thus far. She was very concerned about him being exposed to it. My feeling is that the mortality associated with myocarditis was probably higher than that of COVID, but I could not convince him to go to the emergency room, and nor could I convince the primary care doctor that that was the right move. Fortunately, his symptoms actually did not accelerate. The dyspnea did persist, although over the course of the next couple of weeks, there might have actually been some slight improvement in his symptoms. And that's where things were over the next several weeks. So on April 28th, it was decided to, as he was doing reasonably well, it was decided to give him another cycle of Yervoy. And a week later, I get a call again on May 6th. Again, I have not seen this patient now since the fall of 2019. These are just phone calls that I've had. And he tells me again, a week later after a second dose, that now the shortness of breath is worse than it ever has been. The primary care doctor did actually have him tested for COVID on May 5th, and that was negative. He still refused to go to the emergency room. So it just shows the complexity of like to treat patients in this era of COVID. Come to our outpatient facility for an electrocardiogram, an echocardiogram, and some labs. And you could see that from the time he initially refused to go to the ER to May 7th, the numbers again continue to grow at a very fast rate for the number of cases in Illinois. So here is the electrocardiogram that was obtained on May 7th of 2020, which is on your right, compared to the electrocardiogram obtained in March of 2018. And the key difference between, well, first of all, the similarities, he was in atrial fibrillation in March of 2018, and he had a right bundle branch block at that time with some left anterior, left axis deviation, potentially left anterior fascicular block. In May of 2020, so just several weeks ago when he came in, things for the most part were similar, except now he's having a reasonable amount of ventricular ectopy, PVCs that he's having. As far as laboratory data is concerned, in March of 2018, he did have a pro-BNP checked at that time, which was mildly elevated at 1,077. In our lab, for a man who's in his mid-70s, we would say normal would be less than 450. He wasn't having any heart failure symptoms then. He probably does have some diastolic dysfunction. On May 6th, the day before he came in for the EKG, he did get labs done, and now his pro-BNP was up to 1858. With respect to cardiac enzymes, we changed our assay at our lab, so we were doing troponin Ts in March of 2018. Now in May of 2020, we're doing high sensitivity troponin. For what it's worth, his troponin in March of 2018 was unremarkable, was not detectable. However, his highly sensitive troponin on May 6th of 2020 was elevated mildly at 33. So we have a BNP that's gone up, we have a high sensitivity troponin of 33, and we have some ventricular ectopy on the EKG. So I did get an echocardiogram that day as well in our outpatient facility. And again, his ejection fraction was still preserved. He had the same wall motion abnormalities that he's had for years, where his basal inferior segment was hypokinetic. His pulmonary pressures were fairly similar to where they had been over the years, with a RV systolic pressure of about 40 millimeters mercury. He did have a trivial pericardial effusion, which you can see right here, that was not appreciated on his last echocardiogram a year or two earlier, but it was decided that compared to the previous study, there was no significant change. So here's how the next few days played out. So again, this was May 7th. On May 12th, was finally able to get a cardiac MRI, and as most of you can appreciate, getting quote unquote elective testing in this time of COVID is challenging, but he was able to get a cardiac MRI on May 12th. He called his oncologist, and the main complaint he had to his oncologist at that point was the worsening rash on his upper extremities and chest. He did have a history of mild psoriasis, and again, he had been bothered by some psoriatic exacerbations during treatment with the Opdivo as well, but now it was getting to the point where the rash was so bothersome to him that he couldn't even get to sleep at night despite using the steroid cream. And here you could see on his chest some raised erythematous scaly lesions. Here's one on the back of his knee, and then here's a close-up here, which looks like fairly classic psoriasis. The oncologist, because of the rash, even though he's still having some shortness of breath at this point, significant shortness of breath, began a Medrol dose pack on him. So she gave him 24 milligrams of Solumedrol, which again is about 30 milligrams of prednisone. At that time, he had labs drawn as well, and his sodium was down to 125 from 133 about a week earlier. His creatinine was up to 1.8 from 1.3 a week earlier. His pro-BNP, again, now is 2844 from 1858 1 week earlier. Again, that's in the setting of a creatinine that's gone up from 1.3 to 1.8. And interestingly, his troponin had actually come down. His troponin was down to 22. Normal is less than 21 nanograms per milliliter. He was 33 1 week earlier. And his platelet count continued to remain low at 47,000. So interestingly, again, the steroids were given here, this Medrol dose pack was given for this rash, but on May 14th, one day after starting the Medrol dose pack, his shortness of breath had completely resolved. And at that point there, since he was on the dose pack, he was taking 20 milligrams of Medrol. On May 15th, he continues to have no shortness of breath whatsoever. He's on 16 milligrams of Medrol. And finally, at this time, the results of the MRI come back. Because of his hyponatremia, I decided to change his hydrochlorothiazide to furosemide. And because of his platelet count now dropping below 50,000, I decided to hold his anticoagulation, thinking about the risk of bleeding. The other thing I took into consideration is he did have a May's procedure with hoping that perhaps he's at slightly lower risk of stroke because of that. But I was concerned about the risk of bleeding with him. So at that point there, Coumadin was stopped. So here's the results of his cardiac MRI. And this was read by one of my colleagues at NorthShore, Dr. Persnani, who's an excellent MRI cardiologist. I don't claim to be an expert in cardiac MRI, so I defer to Dr. Personani with his interpretations. He certainly has dragged me out of the fire many a time with his expertise in cardiac MRI. And what was noted is that his ejection fraction was normal. He did have normal RV size and function. And what was appreciated was a small focus of mid-myocardial late gadolinium enhancement in the basal inferolateral and the basal inferoseptal walls. In conjunction with the native T1 time and the extracellular volume, he found these findings to be consistent with myocarditis, and a trivial pericardial effusion was noted as well. So again, this was results from 3 days earlier. So where do things play out from here? So we're now on May 16th, and I talked with the oncologist about the results of the MRI in conjunction with all the other data that we have, including the EKG, the BNP, and the troponin. And one of my concerns with the steroids is, again, he has very, very brittle diabetes. And he had been on steroids a couple years earlier for orthopedic issues, and his sugars really get out of control when he's on steroids. So that was one concern with starting him on steroid. In this situation here, because of the myocarditis and because how well he was responding to these steroids, I decided to not taper his Solumedrol anymore at that point, and just to put him on prednisone 20 milligrams, which is about the dose that he received when his symptoms had resolved. And he was having no shortness of breath whatsoever from this past week, May 16th, May 20th, was having some sleep issues with the prednisone. So on May 21st, I changed him to a shorter acting steroid, hydrocortisone. Again, I think of hydrocortisone as having about a 4-to-1 ratio compared to prednisone. And I put him on 60 milligrams in the morning and 40 milligrams in the afternoon, hoping that some of that steroid would wear off in the evening to allow him to get some rest. Interestingly, with steroids and some free water restriction and stopping the hydrochlorothiazide, his sodium did go up to 128. One of the concerns from his oncologist is that, and rightfully so, is that he may have some adrenal insufficiency from the Yervoy. I did check a random cortisol level on him, although very difficult to interpret in the setting of being on prednisone, and he happened to get it checked in the middle of the day. So not entirely certain whether or not he truly does have adrenal insufficiency. However, by continuing this treatment of holding the thiazide, which again, he had been on for a number of years without any sodium problems, but by continuing him on steroids, his sodium actually, just as of 2 days ago, was now up to 132, and his creatinine was actually down to 1.4. So it does beg the question as to whether or not he may have some renal involvement as well, and the steroids are helping from that perspective.
Jason, did you happen to check a SED rate or a CRP around the time that you were contemplating myocarditis?
So I did check a CRP, and for whatever reason with our lab, it didn't get drawn. So it's still pending there, which, as we know, can happen from time to time. But I do not have a CRP level.
Yeah, I think to detect an immune-related adverse event, there is some evidence that a rising CRP may provide a bit of insight. Now, you still have to try to figure out what the source of inflammation may be, but nonetheless, that could be helpful potentially.
Sure, absolutely, and that is pending, and he actually should be getting that today. Actually. So now I present to the audience here, what would the next step be? So a 78-year-old man with coronary disease, diabetes, AFib, diagnosed with metastatic melanoma in January of 2019. And here you could see his initial PET scan here, very hot, with left upper lobe mass, multiple pleural-based nodules as well. Again, you can see that the heart here not uptaking much much tracer there, has a beautiful response to Opdivo, goes into complete remission with no evidence of any disease, and of course now he's progressing again. So he has this great response. The main side effects that he had to the Nivo/Opdivo during 2019 is he had some rash and some thrombocytopenia, but now he's progressed. And now he's got, again, clear evidence of widespread disease with some liver involvement as well as some involvement in his mesenteric lymph nodes and his iliac lymph nodes as well. And he now to this point has had 2 cycles of Yervoy, complicated by rash, possible adrenal insufficiency, worsening thrombocytopenia, and I would argue probable myocarditis based on the results of cardiac MRI, the EKG changes, the elevated troponin, and his very, very quick response to steroid therapy. Of course, another thing on the differential would be a pneumonitis based on his quick response. There was nothing on the MRI when we did look at the pulmonary fields that would suggest any pulmonary involvement at the time. So my suspicion is that this probably is a myocarditis, but a low-grade myocarditis at that. So as far as checkpoint inhibitor myocarditis, what I wanted to hit on this morning is, again, the grading of myocarditis, a little on the diagnostic assessment, prognosis, management, the idea of re-challenging someone, and then a proposed strategy in this patient. So as a cardiologist by training, and not an immunologist and not an oncologist, I like to remind myself of the mechanism of these complex drugs that are used by the oncologists. So when we're talking about the checkpoint inhibitors, I like to keep things pretty simple. And again, I think about there being a tumor or an antigen presenting cell presenting a tumor protein to a T cell. What we're going to do is we're going to have our immune system accelerate, and we're going to get the T cells going to try to this malignancy that's in our body. Okay. However, we also have the ability to slow down our immune system, and we have at least 2 mechanisms to put the brakes on our immune response. One is via the upproduction that we make of CTLA4, okay, which will slow down T cells, and we also have our PD-1 that when it interacts with the PD-L1 on tumor cells, this is one of the ways that the tumor cells can avoid the immune response. That's a second mechanism to put the brakes on our immune response. So fortunately now we've got at least 3 mechanisms to take the brakes off of the immune system and accelerate the immune system with the goal of trying to destroy the cancer cells. And we have our PD-1 inhibitors, our CTLA4 inhibitors, and our PD-L1 inhibitors. So as far as the grading of myocarditis is concerned, and this is from ASCO, we can grade them 1 through 4. Grade 1, abnormal cardiac biomarkers or an EKG. Grade 2, mild symptoms with abnormal cardiac markers and an EKG. Grade 3, an echocardiogram showing some cardiac dysfunction, some regional wall motion abnormalities, or an MRI suggestive of myocarditis. And of course, grade 4 are people with more of a rip-roaring myocarditis that is a much more serious and associated with very high mortality. So I would argue in this person here, his myocarditis, I would grade somewhere between 2 and 3. We certainly did have an MRI, which was suggestive of myocarditis. And clearly he was having at least moderate symptoms. He was having shortness of breath with very, very little exertion at all. So I'd say probably closer to a grade 3 myocarditis based on his clinical presentation. So as far as the diagnosis of myocarditis is concerned, 2 papers that I wanted to take a quick look at. One is a Sentinel paper by Mahmoud that was published in JACC about 2 years ago. And what this emphasizes here is the variability in the timing of the presentation of myocarditis. So here we're looking at 35 different patients, and here are days after the start of immune checkpoint inhibition. And we can see the timing of when myocarditis first manifests. And there's some people who manifest within the first week or so of the exposure to the checkpoint inhibitors, and there's some people who don't experience until months or even up to a year after their first exposure to the myocarditis. So it's something to keep in mind that there's a wide variability as far as the timing of the presentation. Here's another nice figure from Zhu, and what this here looks at again is a number of different case reports of patients, about 40 or so, and this breaks down the presentation or the diagnosis of myocarditis based on whether or not the patient is on monotherapy, which would be a blue dot, or combined therapy, which would be a red dot. And here we have days after treatment of with the checkpoint inhibitor. And what we can see here is at 4 weeks, 8 weeks, 12 weeks, that's where most of these red dots are occurring here. So people who are on combined therapy tend to have myocarditis maybe a little bit earlier, but there's still plenty of patients here who are on just monotherapy that are having a diagnosis of myocarditis within the first 1 to 2 months. And then the other thing to keep in mind is all the way out here, a year out, again, we're seeing patients being diagnosed with myocarditis or on monotherapy. So very important to keep in mind that these patients can present anywhere along the spectrum after the initiation of checkpoint inhibition. With respect to diagnosis, we certainly like to use our less expensive technology, our biomarkers such as troponin and BNP, echocardiograms, EKGs. I think that one of the hopes with myocarditis is that we would have a definitive answer outside of an endomyocardial biopsy. And so far, the MRI data has been okay, is how I would interpret it. So here, looking at data from Mahmoud from JACC of 2018, same paper, as far as patients who were diagnosed with a myocarditis from checkpoint inhibition, you could see that about 23% or 8 out of their 35 patients had no late gadolinium enhancement whatsoever, which is a little disappointing. I would hope that the majority or the almost 100% would have myocarditis. My experience has been with viral myocarditis that much higher than 75–80% of patients will have delayed gadolinium enhancement. About 18 out of the 35 patients had fairly convincing evidence of MRI myocarditis based on the delayed gadolinium enhancement being subepicardial or mid-myocardial, and 9 out of the 35 had diffuse. This is a recent paper here by Zhang, which was published in the European Heart Journal, and this was a little discouraging, in my opinion, as far as the utility of cardiac MRI with respect to the diagnosis of myocarditis. So the first thing that I want to point out, so if we're looking at late gadolinium enhancement, so here we have our late gadolinium enhancement patients, and here's our patients who had no late gadolinium enhancement. There was about 100 patients in this study, and about 54 out of the 101 patients had no late gadolinium enhancement whatsoever. Okay, so over half of the patients are not seeing any manifestations on the cardiac MRI that would suggest myocarditis, and these patients did go on to be proven to have myocarditis either by endomyocardial biopsy or clinical assessment. So discouraging that 54 out of the 101 did not have any MRI findings. The other thing that I wanted to emphasize, though, in this study is that if you look at those patients who did have late gadolinium enhancement, okay, most of those patients had their cardiac MRI performed more than 4 days after they presented to the hospital. So one of the things to keep in mind with the utility of cardiac MRI in this population is that potentially if you use the cardiac MRI too early, you may not be able to see some of the MRI findings that would suggest myocarditis. So that could be one of the reasons that we saw so many patients in this study who did not have MRI findings. It could be because so many of them had their MRI done very early on in their presentation. Getting back to inexpensive ways of making the diagnosis, back to Mahmood's paper, is that 94% of the patients who did go on to have a diagnosis of myocarditis did have an elevated troponin. So an abnormal troponin, changes on the EKG, again, are less expensive technology, but very, very high sensitivity with respect to making a diagnosis of myocarditis. So with a normal troponin, not impossible, but less likely that we're dealing with an active myocarditis. As far as prognosis is concerned, prognosis is not good. And if we look at the literature here from these 4 papers, the paper published in the New England Journal of Medicine in 2016 showed that over 60% of the patients that were receiving combination therapy with Ipi and Nivo died. Mahmood reported that of the patients who had myocarditis, 50% had major adverse cardiovascular events, including death, cardiogenic shock, or hemodynamically significant complete heart block. Mir reported in Circulation a 35% mortality with his systematic review, and Escudier reported about a 30% mortality. So I think that's safe to say, based on the literature that we have to this point, that the mortality is very significant with myocarditis, ranging from anywhere from 30 to 60%. Getting back to prognosis and looking at cardiac MRI again, I wanted to go back to Zhang's paper, which looked at patients based on whether they had late gadolinium enhancement or they had no late gadolinium enhancement. And unfortunately, if we look at these 2 curves here, there does not appear to be any difference in survival in patients who did or did not have late gadolinium enhancement, which is a little discouraging, because I would hope that cardiac MRI, as it is other pathologic states, could be useful in prognostication. But at least according to this data here, it does not look like the cardiac MRI gives very good prognosis. BNP, echo changes, EKGs have also not been shown to be predictive, but troponin looks like it has. So here, if we look at troponin and we look at patients who have no major adverse cardiovascular events, patients who have major adverse cardiovascular events, and we break it down into what the admission troponin is, peak troponin, and the troponin at discharge, there is a significant difference in troponin levels between those patients who do not have MACE and those who do have MACE. So troponin is still a very strong marker as far as predicting prognosis. So what should the management be? And this is, I think, probably the most challenging part of it. The diagnosis, not easy, but the management, really, where are we getting our guidelines from? So most of the guidelines would say, including ASCO, that a patient with myocarditis should be admitted to the hospital. In this situation here, this was challenging. I could barely get this patient to come to the emergency room, let alone be admitted to the hospital in the setting of COVID. ASCO makes a recommendation that all patients with myocarditis should have their immunotherapy held, and anyone who has more than a grade 1 myocarditis, so again, just mild symptoms or abnormal cardiac biomarkers, they should have their therapy completely discontinued, never be exposed again. As far as treatment is concerned, I think that looking at the literature and certainly the paper by Mahmood, that pulse dose steroids at 1,000 milligrams daily followed by 1 mg per kg daily is something that I have used in the past and something that a lot of you have used in the past to try to get on top of myocarditis early on. There's data that shows that by using high dose steroids early, that probably does benefit them from a mortality perspective. ASCO is not quite as aggressive with their recommendations, and they suggest starting with 1 to 2 mg per kg of prednisone, so a slightly lower dose. There is no consensus on the duration of steroids. ASCO, in their clinical practice guidelines for immune-related adverse reactions, recommends a taper of at least 4 to 6 weeks, again, based on anecdotal data. The ACC/AHA have guidelines for LV dysfunction that we should be following. So patients with cardiac dysfunction should be on ACE inhibitors, beta blockers, and aldosterone blocking agents with ejection fractions of less than 35%. And in patients without an immediate response, there are some recommendations based on mostly case reports for going up on the inhibition of the immune system by doing plasmapheresis, mycophenolate, infliximab, ATG, emiltuzumab, which is a monoclonal antibody for CD52, and then also some of our new CTLA-4 agonists. So one of the questions that I have in these situations is, yes, so I'm not happy about the myocarditis, and I am aware that the myocarditis does portend a very high mortality. But he also has an underlying disease process that, again, without treatment, good treatment, has really 100% mortality with his metastatic melanoma. So looking at the literature, I asked myself, well, if I'm going to give steroids to this person, am I just going to replace? Am I going to treat the myocarditis and now I'm going to let the melanoma go wild? And here are two papers, one from Journal of Clinical Oncology, actually both from the Journal of Clinical Oncology, one looking at Ipilimumab and the other one looking at Opdivo. And when we look at the survival of patients who have received steroids, and again, different reasons for receiving steroids. Most of these patients were not receiving them for myocarditis. They were receiving them for brain metastases or colitis or dermatologic manifestations, adrenal insufficiency. But there did not appear to be any difference in survival in patients who had steroids versus those who did not have steroids in the IPI group, nor did there appear to be any difference in survival in the group that had steroids versus those that did not in the Nivo or Opdivo group. So it seems to me that there's no question that steroids need to be used in this situation here. And it looks fairly reassuring that by giving steroids, we are not significantly decreasing the efficacy of inhibition. And now this is where I am right now. This gentleman has received 2 cycles of Yervoy to this point. I think based on these PET scans, we have a pretty good idea of where his disease is going to go if he does not receive any more therapy. And speaking with his oncologist, this is kind of the last therapy that she has for him. So as far as rechallenging is concerned, there is really a paucity of literature out there to help guide us. Again, ASCO would recommend really never allowing this person to be touched with immunotherapy again. Escudier did look at patients who were rechallenged, and 4 of his 30 patients within his subgroup with myocarditis were rechallenged. And of those patients, none of them had any recurrence of the myocarditis. So that's one paper, again, just 4 patients that did fairly well with rechallenging of a checkpoint inhibitor. However, here's another case report by Tajmir. And he has a patient who's 72 years old who developed myocarditis from Nivo. His ejection fraction went from 50 to 15 and was started on Solumedrol. Ejection fraction came up to about 30% at about 2 months. His clinical symptoms subsided. He did try to reintroduce an anti-PD-1 therapy, and it caused significant flare of myocarditis. So it's really a big question as far as, what do you do with these patients? I think a lot of it is based on us, the cardio-oncologists, talking to one another and getting an idea of what one another's experience has been. So I had a lengthy discussion with the patient, and this was the proposed strategy that I came up with. And this somewhat goes along with the current NCCN guidelines, which are a little less strict than the ASCO guidelines as far as what to do with these patients who do have myocarditis. I think that most of us would agree that with someone with a grade 4 myocarditis, so life-threatening disease and proven myocarditis, that pulse dose steroids is the right thing to do. The drug should be discontinued. If these patients deteriorate even more so, we should be thinking about second-line agents. And as far as monitoring these patients, be checking cardiac enzymes and echo to assess for clinical improvement or further deterioration. For those who improve, who have a grade 4 myocarditis, I think that a 4 to 6 week taper could be reasonable. And I think that we have to very closely survey these patients and continue to check cardiac biomarkers, consider mobile telemetry or an implantable loop recorder to see if they're having any significant arrhythmias, and getting an echocardiogram every 3 to 6 months just to make sure that they do not continue to deteriorate from a rhythm perspective or a myopathy, or a cardiomyopathy perspective from the insult they received from the checkpoint inhibition. For patients with grade 1 and grade 2 myocarditis, I have a difficult time being as or following the strict guidelines by ASCO, especially in a patient like this, doesn't have many options with respect to his melanoma. So I would agree that steroids is the right choice, and I certainly am starting with steroids. Whether or not high dose steroids are needed in every patient, I'm uncertain. I know there is data that shows that high dose steroids may have some mortality benefit. Here's a gentleman with very brittle diabetes who I am fairly confident with high dose steroids is going to have sugars of about 500 or 600, despite aggressive insulin therapy. And it begs the question, similar to the data that we have from the sarcoid population, where it doesn't appear to be that there's much of a difference with the sarcoid patients, whether we use high dose or low dose steroids with a infliction point of about 30 milligrams of prednisone. So patients who get less than 30 milligrams of prednisone seem to do just as well as the patients who get more than 30 milligrams of prednisone. So maybe high dose steroid is not needed by everybody. And in this particular situation, it was pretty dramatic. Again, this was after the second cycle of Yervoy, pretty dramatic how well he responded to just 20 to 24 milligrams of Solumedrol. The symptoms completely resolved within about 24 hours or so. And I would argue to consider continuing the drug, and this is something that the NCCN would also consider, again, after a discussion with the patient. If a patient deteriorates despite continuing the drug, certainly increasing the steroids to higher dose would be my first approach. Second line agents could also be considered, and then a troponin or echocardiogram to follow for worsening disease. For those who improve, such as this patient who has improved so far, I like the idea of continuing with immunotherapy. And at this point right now, we are strongly considering giving him his third cycle of Yervoy, either the end of this week or early next week. And then the question comes up, and again, there's really not a lot of literature to support, but do you still taper this person if we're going to continue to give him immunotherapy? I'm pretty confident that his adverse reactions are going to continue. So maybe this is somebody that we just continue on a low dose of steroids while he's getting therapy and not do a complete taper. And as far as surveillance is concerned, again, there's really no literature out there or guidelines as far as what we should be doing with these patients who we do continue on immunotherapy who have had myocarditis. I think at the very least, we should be getting troponins every 2 to 4 weeks or so, making sure that we're not seeing a large jump, maybe even more frequently than that. With this patient, my plan is, once we get him back on therapy, is to use a mobile telemetry device, an external device that I can check on a daily basis from the company, just to make sure that he's not having any significant arrhythmias such as heart block. Remember, he's got a right bundle and he has probably a left anterior fascicular block. So this is somebody who there is some concern on my end that he could develop complete heart block. Looking for an increased burden of ventricular arrhythmias. And again, if I were to see suggestion of heart block or more ventricular arrhythmias, question would come, well, do we stop therapy, increase dosing of immunosuppressives? And that'll be, again, a lengthy discussion with the patient and the oncologist. And certainly if we're going to continue with therapy, getting echocardiograms at least quarterly to twice a year to make sure that we're not seeing a significant change.
Hey, Ashley, so I looked at it. What's her primary cancer?
Melanoma.
Okay.
Okay, so, and then as far as grade 3, I think that one needs to consider risks and benefits. And again, in this patient here, really you could call him a grade 3 based on his cardiac MRI. And again, even though he is closer to a grade 3, I would still consider continuing therapy with him just because there's not a lot of other options for
Yeah,
therapy.
I mean, Jason, I would say that at a minimum he was grade 3, but if you remember, of course, in your description, on several occasions you advised him to be admitted, and he didn't want to be admitted. So usually the distinction between grade 3 or 4 and grade 2 or 1 is whether somebody needed to be hospitalized for that problem. So at the absolute minimum, he had grade 3. I would say
Okay,
probably
sir,
probably grade 4, because you said probable myocarditis based on the whole picture, etc. So I think that this one's really tough. There is no right answer, but I would say that at least from general experience in dealing with patients with myocarditis, if I'm pretty convinced that's what they have, that is a very serious problem, as you pointed out, and re-challenging them would be very risky. So, I mean, that would be the way that I would summarize it. I think if you have some other cardiovascular event that's not as serious, then, they can probably be re-challenged safely. But in somebody who you're pretty convinced had myocarditis, I think you got to look for other avenues of therapy.
Dan and Jason, if I could add, Jason, again, great presentation, very informative, and thank you. We've had quite a few patients more recently who have had pre-existing cardiovascular disease, especially coronary artery disease, that present with, similar symptoms and mild elevation in troponin. And as both you and Dan pointed out, I think in those patients, we want to be pretty clear that we have made the correct diagnosis. And in this patient, given the temporal trend, the presentation, what, as Dan pointed out, prior PET studies, it's suggestive that this is likely, very likely myocarditis. One of the things that played an important role in you making the diagnosis of myocarditis is also the cardiac MRI. And remember the features that were identified, which was elevated ECV, LGE, and T1 values, are all markers of fibrosis and not necessarily markers of edema, which means that some of the events that this patient had may relate to the PET findings earlier on, and the current presentation may not have been sort of acute myocarditis. Unless you show some form of changes in T2, it doesn't necessarily mean that what is going on is acute. So I think some assessment of coronaries would be important. For example, we've had patients with NEPO and Ipi who are presented with troponin positive syndrome, but an MRI that was not suggestive, and we ended up cathing them, and they had progressive coronary disease. So I think just not necessarily in this patient, but big picture, providing you're committing them to long-standing steroids as well as potential permanent cessation, as Dan pointed out, of their immunosuppressive therapy. We still want to rule out common causes given the patient population we care for, including coronary disease, before making the diagnosis using non-invasive methods.
That's a great point. Yep, I agree.
It's Joe. So nice job. A couple of things in the Escodier paper, it wasn't clear which people they re-challenged. So it may be that they were all grade 1. We've seen a curious phenomenon, and that is that in people who have had myocarditis, and we've just watched them for any change in their and it's been mostly melanoma and/or lung cancer progression without further treatment, and we've actually just held off and conservatively watched people closely before even discussing re-challenge. That a lot of them go months and months and months and maybe forever without having to retreat from the basic value of the immunotherapy that they got prior to myocarditis. So watch and wait strategy from an oncology standpoint is not outrageous.
Let me ask you a question from an oncologic perspective. The one piece of data that I didn't share is the LDH levels. Is LDH had been normal throughout at the time of diagnosis and throughout therapy. And now most recently, the LDH, our lab, the upper limit of normal is about 200 or so. The LDH is now about 250 or 300. In your mind, does that suggest that this is related to progressive melanoma disease?
I would honestly say that that may indicate that something hematologic was going on, more along the lines of, you had persistent thrombocytopenia. So I would say that rising LDH is probably more indicative of a consumptive type process from the hematology perspective.
Okay. Well, I thank everyone. So I appreciate everyone's thoughts. To Chicagoan, I hope some of you had the chance. Maybe you're not as into it if you're not from Chicago, but this was a documentary that's been on over the last month and a half or so, since there's no sports to watch. It was a documentary of the Bulls in the 1990s. And again, I talk about the great movies that were made here in the 1980s, but I think there's nothing that defines the city more than this guy here, Michael Jordan. So that's my final suggestion for everybody. At the end, there's my email at the bottom, and I would be happy to get any more comments from people or suggestions I didn't hear from today.
Super. This was really a fantastic presentation. You showed us the complexity, and good luck with your future conversations with this patient. But I will say that there's probably no real right answer. There may be some wrong answers, but it's a real challenge, and we really appreciate you sharing that.
My pleasure. Thank you for having me.
That's terrific.
Thank you so much, Jason. Appreciate you being here. And thank you everyone for